Welcome to Mind My Age, presented by Total Life. I'm your host, Neelam Brar. Today we have an extraordinary guest and a critical topic to discuss: chronic pain management and mental health. In this episode, we will explore the intricate relationship between chronic pain and mental health and how innovative psychological approaches can help manage chronic pain effectively. Joining us today is Dr. Beverly E. Thorn, a renowned psychologist, researcher, and author. Dr. Thorn has extensive expertise in chronic pain management and cognitive behavioral therapy. She holds a significant position at the University of Alabama and has made remarkable contributions to this field through her research and publications. So great to have you today.
Thank you. It's great to be here.
Dr. Thorn, at Mind My Age, we believe that your mind controls your health. So I'd like to start with, how old do you feel and why?
So I feel I'm not yet eligible for Medicare, which is not true. I'm 71. So I feel about 60.
I love that. What do you think is your approach to life that allows you to feel younger?
It's a multitude of things, but I do think that, first of all, I eat pretty well. Second of all, I exercise a lot, and I always have. That's been my lifestyle since high school. I should talk about it as physical activity, not exercise, because exercise is intimidating to people. But I have a lot of physical activity, and I think that is so important as we go on in life. And I have a lot of social contacts, good social contacts, and I think that's very, very important. Plus, I do a lot of stuff with my mind. I'm constantly interested in new stuff and pursuing new stuff, and I think that's important as well.
That curiosity can really keep us young. So, Dr. Thorn, your journey has been remarkable. Can you share with us what has led you to focus on the overlap between chronic pain and mental health?
Yes, I think to me, it's pretty interesting journey, because in graduate school, I was dual trained as a neuroscientist, which is the study of the brain, and as a clinical psychologist, which is in many ways the study of the psyche. And back then in the Stone Ages, when I was getting my degree, we really didn't combine those two things. So it was either biological or it was psychological. And to me, that was kind of silly. And I remember one lecture one day, the professor used the example of cancer. And cancer, he didn't talk about cancer pain, but I asked him about it. Basically, what he said is the research shows that two people with the identical cancer, the identical life expectancy, one of them could be up, interacting, doing stuff, engaged, and one of them could be in the bed, totally debilitated. You can't explain it by the biological disease process alone. And so I wanted to take that and use it as a way to combine both the what we call sometimes organic or real, the physical, and the psychological, which some people disparagingly call psychogenic or not real. And I wanted to show that both are real and both are involved, especially in chronic pain. All pain is both biological and psychological. That doesn't make it any less real.
Absolutely. And, your mind does control your health. And so ensuring that folks are addressing their physical diagnoses with a fit and stable mindset is critical, right?
Hugely important. And to learn skills associated with addressing physical anomalies as they come up, because that's part of life. We all have physical challenges and hopefully get over them. But we also get over them much more quickly if we learn some skills to develop a mindset that helps us see it as a challenge rather than as a loss or a threat.
Absolutely. You've conducted notable research on cognitive behavioral therapy for chronic pain. What are some tools or resources or tips that you can share with our listeners who are navigating chronic pain?
One of the things that I studied a lot, sort of in mid-career, is something called pain catastrophizing. And that is really awfulizing about pain. And I know about it because I have had a history of migraine headaches. And so one of the things that I would do when I got a migraine aura is I would go, oh my gosh, I can't afford to have this aura now. I can't afford to be in the hospital now. I can't afford to go to the emergency room. I've got way too much. Well, guess what happens when I awfulize like that? My pain level goes up and my migraine gets worse. Rather than if I learn to say, and I have learned to say, and I've taught patients how to say this is a sign that my body needs to do some resting right now. And I'm going to take care of myself by doing some resting. That is a hugely different way of approaching it in our head, our self-talk. So one of the things that I really expanded upon in my research and in my therapy is helping people, first of all, be aware of their self-talk because it's on under the surface often. And second of all, be realistic in their self-talk.
So be aware and be realistic.
Well, be aware and be realistic. And realistic is not Pollyanna. So it's not for me to say, you don't have a migraine. It's okay. It's all going to be okay. Because realistically, we're faced with a lot of serious physical challenges. But what we do when we awfulize, we have these self-defeating thoughts that make things so much worse. So first of all, we have to be aware of them. Second of all, we have to say, okay, how much do I believe that awfulizing thought? And if it's really controlling my behavior and my emotions, how can I manipulate that thought to be more realistic and to be more working for me than working against me? And so we actually teach people to make a little chart with us and talk about the thought that they're having and how it's impacting their emotions and their actions. Because thoughts, feelings, and emotions are all working together for our good or for our bad, for our ability to cope or for our ability not to cope.
So in addition to mapping the thoughts, feelings, and emotions, what strategies can our listeners use to manage the chronic pain through cognitive behavioral therapy and other psychological approaches?
One of the things that I was talking about is the cognitive part, but cognitive behavioral therapy involves a whole lot more than that. We do a bunch of relaxation strategies. We give people a smorgasbord of relaxation strategies that they can use to calm their bodies and calm their minds down so that they can step back a little bit emotionally and see what's going on. So we do relaxation. We also teach meditation, and meditation is a little bit different from relaxation. Most people get relaxed when they meditate, but meditation is teaching people to focus on their breathing. And when they have thoughts that come through as they're meditating, to just observe the thought without judgment and then allow the thought to pass rather than grabbing onto that thought and going, oh my gosh, it's going to be terrible. So we teach meditation. We also teach people to pay attention to their physical activity. When we have pain, we tend to withdraw physically. And we go, oh, it's too bad, I can't do that. We have fear of pain. And when we become immobile, we actually get worse rather than better. So those are a few of the strategies.
So what are the latest research findings in chronic pain management, including your contributions, for our audience to be thinking about?
I think the main contribution that I have made in the latter part of my career is to be able to prove, to be able to show that we don't have to have a real fancy techno jargon kind of pain management treatment to help people. And so what we did is we went into what are called federally qualified clinics. clinics that serve people with low income, and most of them happened to have low literacy levels and low education levels. We were able to simplify the jargon, get rid of the jargon, and we were able to teach people these pain management strategies, some of which I've mentioned today. And we were able to show that cognitive behavioral therapy simplified, plus whatever medical treatment they were getting, and usually it wasn't a whole lot of medical treatment, that reduced their pain levels, their depression levels, and increased their engagement in life activities. And those are the three hallmarks to our treatment programs. Will it reduce their sense of pain? Will it reduce their sense of depression, because depression is definitely related to chronic pain? And will it increase their ability to engage in life, because it's all about quality of life. And we were able to show that even in populations that weren't necessarily highly educated, this cognitive behavioral therapy wasn't all that abstract and wasn't all that technical and could be used by everyone. And we developed workbooks for patients that was much more simplified kind of treatment approach. And I think that was a good contribution that was made.
So, based on those workbooks, can you discuss some of the treatments and therapies for chronic pain that are emerging from the research you've done?
Well, from the research I've done, there have been a lot of researchers that have used my program to try to test it. So, for example, all of my work was done with group treatment, and it was face to face. Well, nowadays we're really using the technology opportunities that we have to reach more people um, online, etc. So I have a colleague who's testing my treatment program to see if it works as well online. Do people stay as engaged online? It is still a group treatment. Does it work for individual treatment approaches? Does it work in different languages? So all of that's being tested. The other thing that's an innovative piece of cognitive behavioral therapy that's not really part so much of my research, but a new offshoot of cognitive behavioral therapy. We've paid a lot of attention in our research programs to cognitive thought processes and behavior actions, but we haven't paid a whole lot of attention to emotions. And so now that the piece of the puzzle in cognitive behavioral therapy seems to be moving toward, let's pay more attention to someone's emotions, get them to be aware of their emotions, like they're aware of their thoughts, and get them to be able to express their emotions. So, for example, we have an exercise where we teach people something called expressive writing, or it can be expressive speaking. And they write down all their thoughts and feelings about a current situation. It's just for them. But to be able to get that out seems to be very beneficial.
Right. They say with feelings, you first need to start naming them in order to tame them. Is the saying, right? You got to name it to tame it.
Right. And you don't have to worry about that label. You don't have to go, oh, is that the right label or anything like that. But to be able to be aware of it and be able to express it, even if it's just to yourself, is very useful.
On the concept of gate control theory in pain management, you mentioned that the brain decides when we are in pain. Refer to that pain gate in the brain. Can you explain the gate control theory and how thoughts and emotions influence pain?
Sure. And this is a piece of research that was hypothesized in the early 70s or the mid 70s, the idea that there's a gating mechanism. Originally, the researchers said there's a gating mechanism in the spinal cord. And so when pain signals, let's say you stub your toe, let's say you break your foot, when pain signals go up the leg and into the spinal cord, there's a gate. And that gate can be open wide, or it can be not so open wide. And especially for chronic pain, What we know now is there's more than one gate. There's gates in the brain as well. And why is that important? Because when those pain signals get up to the what I call the ouch area of the brain, if the gates open wide, then the ouch is really big. Now, those signals actually go through areas of our brain that control our emotions and our thoughts. And so, if you are saying to yourself, oh my gosh, I can't take this, my life is over, that gate, that pain gate is opening up, opening wider to more pain signals. And if you tell yourself, I'm so depressed, my life is over, and you feel that and you focus on that depression, that pain gate gets wider. So what we deal with in cognitive behavioral therapy is get people to recognize their emotions and their thoughts, get people to express them, get people to deal with them, and it actually quiets down that activity in the filter of the brain getting to the ouch center, and it's actually closing more, narrowing the pain gate.
What's interesting in your work is that you mentioned 3 out of 10 people have chronic pain, and most people with chronic pain have pain in more than one part of their body. Everyone's pain is different, but people share also a lot in common. How can connecting with folks in the community or peers help people manage their chronic pain and improve their suffering or reduce their suffering?
You know, the number one thing that our participants talk about very quickly into the pain management program is they say, oh, I'm not alone. I'm not alone. They feel alone. They feel like a freak. They feel dismissed by the medical system. And suddenly they're in a group of people, virtually or face to face, with different pain, but similar circumstances. And they come out of there, that first session, they go, I'm not alone. And that is hugely empowering. And by the way, that doesn't fit just for chronic pain. That fits for all different kinds of chronic illnesses and chronic stressors in our lives. So I'm not alone is a really important piece of that.
Yes, and stress makes pain worse, as you say in your booklet. Stress and pain are related. So bringing down stress is a healthy way to make pain better. What are some strategies to bring that stress down?
What I always tell my participants, what I always tell my patients is bringing down stress in a healthy way is going to help you. Sometimes people try to bring down stress with alcohol. Sometimes people try to bring down stress, and often people with chronic pain try to bring down stress with with pain medication. And they are not, in my experience, there are very few pain patients who are drug seekers, but with the pain management medication, sometimes they will take the medication, not necessarily because they need it for the pain, but because they are so stressed out and they don't know any other way to do it. So we teach them to bring down stress through relaxation, through meditation. If they are a prayerful person, we encourage them to think about how they are praying, because there's some interesting research to show that people who pray for the pain to go away, to be gone, never come back, don't manage as well as people who pray to be helped to manage their pain. It's more of an acceptance issue, but help me manage my pain. And of course, when we're doing that, we are changing our thoughts in a helpful way inside of our heads.
In your booklet on managing pain, you mentioned that the stress response has 4 parts: your body, things like blood pressure going up, muscles getting tight, getting sick. Number 2, your emotions, feeling scared, feeling sad, feeling mad. Number 3, your thoughts, trouble making decisions, feeling confused. And finally, number 4, your actions. When you work with patients on these 4 items, what are some stories that you can share with us that this approach has helped improve the pain and the pain management for a patient.
Yeah, one of the things that we do a lot of in every session is we talk about the think, feel, act model. So every time we talk about pain, we talk about thoughts, feelings, and actions. And I actually wrote down a quote from one of our patients in a group that that she actually ended up in the New York Times about our research in 2016. But I wrote this down because I thought it was very interesting what she said. Let me see if I can find it. She said that the cognitive behavioral therapy was the best balm by far for her chronic pain. And she had had a lot of medical treatments. She said, I learned so much about the pain and the brain and how it processes that I was shocked. And she said, then it seems to be about triggering your brain to go to something else other than the pain. And I thought that was pretty well put from a patient who underwent a 10-week group cognitive behavioral treatment program with the workbooks that you were talking about.
And another interesting anecdote in the workbook is just reframing what a stressful event is, whether it's a threat, a loss, or a challenge. A threat is something that can harm us. A loss is something we cannot get back. And a challenge is something that is hard, but we can do it. So I'm assuming we want more people to frame that event as a challenge, right?
There's some interesting research on this too, some of which is mine and some of which is others. But basically, people who view their chronic pain or other stressful events as a challenge actually cope much better than people who are focused on the stressful event as a loss or a threat. And so I use the example of let's say your child or your grandparent, your grandchild is trying to get a job, and if they're trying to get a job and they say to themselves, "This is never going to work. I'm just not going to get a job." How do you think that self-talk is going to affect their emotions? And how do you think that self-talk is going to affect their behavior? And everybody pretty much says they're probably not even going to show up for the interview because what's the use? It's a loss. Or it could be a threat. And that self-talk would be, oh my God, they're going to hate me. They're not going to like what I have to say. They're not going to hire me. So what happens then is people get very anxious. And once again, they don't show up. But if somebody says, you know what, I'm going to do the best I can, and I'm going to get in there and give it a try, then they show up. And if you show up, you often get the job. Different ways to look at the exact same stressful situation.
You mentioned a lot about breathing and the correlation with breathing and stress and breathing and pain. What are some breath techniques that can support relaxation?
So there's a lot of different breath techniques, but one of the techniques that I teach is called belly breathing. And basically, most of us breathe from the top 2/3 of our lungs. And interestingly, we don't do, especially when we're anxious, we may breathe from the top third of our lungs. Everybody's heard of hyperventilation. One of the reasons hyperventilation occurs when we're very, very stressed and anxious is we're breathing from the very tip top of our lungs and we're not getting enough oxygen into our body and into our blood. So belly breathing is a technique to get people to pay attention to drawing the breath deep into their lungs. And when you do that, your belly actually expands a little bit, like a balloon. And then when you exhale, your belly actually retracts a little bit, like a deflated belly. So they get the idea by, I usually have them put one hand on their chest and one hand on their belly. And as they inhale, to sort of make sure that their belly is expanding, and then make sure as they release their breath, their belly goes back down. And we actually have them slow their breathing down too and pay attention to the process of breathing.
That's fantastic. While you were actually speaking about it. I was trying to follow along and do it, and it does have a calming effect for sure. Another concept you mention in your work is putting yourself in charge, growing a feeling of, I know I can do it, and having a strong belief in yourself. What are some ways our listeners can put themselves in charge?
It's interesting that you ask that because it is a mindset, but it's also an interesting behavior. And what we talk about in our groups it's a different term. It's less technical term than assertive behavior or assertiveness. But we teach people something called stand tall talk. People with chronic pain and people with other chronic illnesses sometimes feel very guilty that they're putting other people out. And so they don't ask for what they need. But in the back of their mind, they're going, if she really loved me, she would know what I needed and she would do for me what I need. That doesn't work. We're not mind readers. So stand tall talk is asking directly without apology for what you need and also being able to say no in a simple, non-apologetic manner when there's something that you don't want to do or there's something you don't want to respond to. We are all terrible about being assertive. We all think we shouldn't have to ask, and we all think we shouldn't say no. And you don't have to say no in an angry way, and you don't have to ask in sort of a punishing way like, you never do this for me, and if you love me, you would do this for me. We teach people how to do that in a way that doesn't threaten people and keeps the conversation open.
I find it fascinating that you talk about pain and the fact that the brain decides when you are in pain. Um, my age, we talk about how the mind has so much influence on your physical health. And so it'd be great if you could share with our listeners through your research what you've learned about how pain works in the brain.
We know so much more about how pain is processed in the brain now than we did in the 1980s. And what's interesting is, the neuroscientists are still working at the little little miniature level of this neuron is talking to this neuron, and it uses this chemical and that chemical, and these medications work on this chemical. And that's all fine, and that's very important. But it's also important for us to know about the power of the brain and how we can harness that power. And once again, we go back to the cognitive thought processes, and we go back to the emotions, and we also go to behavior. If you are laying in the bed all day long, not only is your behavior not good for your physical health, it's not good for your emotional health. So what's going to happen is your cognitions, your thought processes are going to downward spiral more and more and more. I can't, I won't, I can't do that. I can't do that anymore either. And then we're going to get depressed. And so to be able to tap into those is tapping into the power of your brain that you have control over. It takes some practice. It's not just snap your fingers and, oh yeah, I'll change my mindset. It takes some practice. It takes some training.
In your research, you talk about like things that open the gateway to pain. That includes things like depression, anger, fear, unhelpful thoughts, the negative self-talk, the underdoing, so less physical activity, sitting down too much, or even the overdoing, too much physical activity, where you've been standing too long or pushing yourself too hard. What I find interesting is you mentioned even pain medicine opens the gate sometimes.
Yeah, let's talk about overdoing and underdoing first, and then let's talk about pain medicine, because both can open the gate. If we underdo, it can open the pain gate, but if we overdo, it can open the pain gate to more pain signals. And there's sort of a subcategory of people with chronic pain who, when they're feeling good, they'll jump up and do way more than they should do. I had a patient who wasn't even walking to the mailbox. And then when he heard our talking about we need to do more physical activity, the moment he felt good enough, he went and walked 4 miles. This is somebody who hasn't even walked to the mailbox. He is what we call a classic overdoer in that situation. So we had to teach him how to pace his activities and pace his behaviors. And we also have to teach the underdoers how to get up and do one little thing, something that they know they can do. It might even be something they think they can do so easily it's not even worth doing. Let's start with that. Then we can add incrementally. Now, you talked about the pain medications. Pain medications are great for something we call acute pain or short-term pain. Short-term pain, it's like if you break your leg, it's very helpful to have pain medications while you're getting that leg set or immediately after post-surgery. The problem with pain medications is after about 2 weeks, they're not really doing anything for your pain. And why we sometimes take them at that point is because, first of all, sometimes we're told that you can continue taking them, take as many as you want, or whatever. And second of all, we're afraid. We're afraid of the possibility of pain. So I have plenty of patients who are really taking way too much pain medication, and they'll say, if I feel this bad when I'm taking all of this pain medication, what in the world am I going to feel when I'm not taking that pain medication? They're astounded to find out that reducing their pain medication can actually reduce their pain.
If you think about closing the gate, a lot of the techniques take discipline and they take building a routine. Can you speak about an experience with a patient where you really built that discipline into their day-to-day?
It's so interesting to me that with this program, first of all, it takes practice. And I would say it's more about practice than it is about discipline. And one of the things that I think is really important to motivate people is we're not going to have them be marathon runners. That's not our goal, right? So our goal is to get them to do small incremental changes in our behavior. And we know from tons of research that small incremental changes eventually make a habit and eventually make a lifestyle. So what we do to motivate people is ask them to pick something small, but to make a goal for that. And then we ask them, what's going to get in your way? What's going to help you? And to have that plan ahead of time. And then we make sure that we're not asking them too much or that they're not asking themselves too much as they're changing a habit. Because habit changes take a long time. Yeah, they take discipline, but I think more so they take practice and consistent practice. And if I ask somebody to run a marathon, they're going to stop. They're going to not do it at all.
It's the entire process of breaking down a large goal into small chunks and then being forgiving when you miss one, jumping right back on and trying again. For our audience listening that might be dealing with chronic pain or have a loved one that's dealing with chronic pain, what is your pain prescription on what they could be doing starting today after they finish listening to this podcast to better manage their pain day to day, week to week?
So are you talking about the loved one being helpful, or are you talking about the person that is experiencing the chronic pain? Because it's sort of two different things.
Let's start with the person themselves.
The person that is experiencing chronic pain, what can they do right away is I would say that being able to sit down for 15 minutes and pay attention to your breathing and get quiet. Pay attention to that belly breathing and get quiet. By the way, the loved one can be doing it too because they're usually stressed as well. And so it's a helpful technique that they could do together. And it's a well behavior. We talk about well behaviors versus not well behaviors. And every time they engage in a well behavior, and they typically know what those are and what they're not, that is contributing to their health and their well-being.
And what about if you were coaching a loved one?
So if you're the loved one, one of the things that we found in our research is there are people, loved ones, who are what we call overly solicitous. And those are the people who say, no, 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 dear, please don't get up. Don't get up. I will get that for you. No, I don't think you should do that, dear. You've had so much pain. I really don't think you should do that. They're overly solicitous. And what we have found is that people with loved ones who are overly solicitous actually have more pain rather than less. And they have more depression rather than less because they don't feel useful. On the other hand, loved ones who say, I'm sick and tired of your chronic pain and there's nothing I can do for you, and they're angry, those people don't necessarily have more pain, but they have way more depression. And so we don't want that. So we want to help loved ones strike a medium, a healthy medium. And basically we want them to encourage well behaviors, to encourage and reward well behaviors. And the term we use is reinforce, but it's just a reward. Give them praise when they do something for themselves. Give them praise when they give it a try.
Chronic pain can really make you angry, frustrated, sad, depressed. And that often impacts how you feel about yourself, but also how you might be communicating with others. One of the facts in your pain research you share is that there are 3 ways of talking to others: the attack way, the retreat way, or the stand tall way. Can you elaborate for our listeners what that means?
Sure. And I mentioned the stand tall technique, but I didn't mention the attack or the retreat, and it's a very useful one. Retreat is when we don't ask for what we need and we are a doormat and we don't feel like we deserve to ask for what we need, and so we shut up. Except then our gunny sack gets full of rocks and we explode and we do the attack talk thing. And then it's, you never listen to me. You never do this. Why do you ask me to go to the movies? You know that I can't go to the movies. I can't sit there. Why do you even ask? And what we're doing, of course, when we do that is we're driving people away. What we do when we have the retreat talk is we're guaranteeing that we're not going to get our needs met. So the stand tall, once again, is asking for what you need without apology in simple ways. And sometimes saying, this will really help our relationship, or it'll help me get up and do more. And that's the whole goal. So what we try to do is get people to pay attention to attack talk when they have it and retreat behaviors when they have it, and move more towards assertiveness or stand tall talk. And once again, that's useful for all of us, whether we have chronic pain or not.
One of the things in your research I really loved was this concept of thoughts and facts being different. A thought is just an idea. Just because we have a thought doesn't make it true. Sometimes we believe things that are not true, and sometimes thoughts are partly true and partly false. Our thoughts are not set in stone, and we can change our thoughts to be more helpful. So for those listeners that are listening today that are having negative self-thoughts or self-speak, what are some exercises we can give them to help identify the narrative and change it?
So for example, when I talked about my migraine auras, when I say to myself, if I have a migraine aura, I'm going to end up in the emergency room for sure. That is a thought. And what's the evidence for that thought? What's the evidence for that thought? How many times have I actually arrived in the emergency room with a migraine headache? Well, I can tell you that once in my entire life. So am I going to end up in the emergency room for sure? Actually, probably not. Probably not. So to be able to challenge that thought and say, that's not terribly realistic and it's certainly not helping me is a very useful technique. So first of all, you have to be aware of your thoughts. Second of all, you have to ask yourself, are these realistic thoughts? How realistic are they? And then third of all, we help people construct alternative thoughts that the thoughts work more for us than against us. We also have something called a sort of frequent flyer thoughts that are really important. Like if you find yourself saying always, never, things like that, usually they're not completely true, because usually in life nothing happens always. Nothing is never. And so you can hone in on that. Like, you always do such and such. Probably not. I never have done such and such. Probably not. And you can say, oh, those are red flag words. That probably means this thought isn't completely realistic.
And finally, there's this idea around coping that you discuss a lot in your booklet. And can you give the audience some sentences around coping that they can start using to manage their pain and thoughts?
Yeah, coping self-statements are a really important part of replacing that negative self-talk, but also they're sort of our cheerleaders for when we need a little pumping up. And one of my patients actually came into the group one day and she said, all right, I took all my coping self-statements and I pinned them on to my throw pillows in the living room. And I told my grandchildren that they were not to touch those throw pillows in the living room because I wanted to go around and I wanted to look at my cheerleaders. And so the grandchildren actually helped by reading the coping self-statements. But these are, and I've got one other example that I think is so perfect. We were sitting around in a group one day, and one of the patients said, look at us. We're the walking wounded. And somebody else said, we're wounded, but we're walking. And they all decided that was a great cheerleading statement. And so things like that, to be able to turn it to a more positive, more hopeful, more challenge rather than loss or threat, are very important. And so we help people construct them. We also give them a list of possibilities like we're wounded, but we're walking, or I'm not giving up. But it's sort of individually tailored depending upon the person.
So, Dr. Thorn, your next book is focused on dementia and caregiving. Can you shed some light on some of the work that you're doing in that field and how our audience can learn more?
Sure, it seems sort of like a hard right turn, doesn't it? But really, my work has been all through my career helping people cope with chronic illness. And dementia is a chronic illness. And on a personal note, my husband was diagnosed with Alzheimer's disease in 2014, and he passed away in 2020 of Alzheimer's dementia. During this time, I was journaling. That's one thing that I recommend that patients do to help them process all of the emotions and all of the stress associated with helping somebody with a chronic disease. And I was also posting some of the stuff that I wrote on dementia caregiver websites. And the feedback that I kept getting was, you need to write this down. You need to write a book about this. And I have written books. I mean, I've written books about coping with chronic illness being pain. So I decided that I would draft a book on my own personal experiences with dementia caregiving, which is very stressful, and also my insights that I developed, the knowledge that I developed. And I had a lot of knowledge because as I said, I was a neuroscientist and a clinical psychologist. Since my husband died, I've actually been certified as a end-of-life doula, end-of-life companion as well. So I took all of that information, added it to my personal story to show that I too can be vulnerable. And I think that's a really important part of being a helper, is to be a human being. Shared my insights, shared my knowledge, and then shared electronic resources at the end of each chapter so that exhausted caregivers could just read a short chapter, look at the insights, remind themselves of those things, and then click on the electronic resources that are at their fingertips. They don't have to go to the back of the book and go through the index and all of that stuff. So we'll see how that goes.
So a practical guide for folks that are navigating that situation in real time. We'll definitely bring you back on the show.
A practical guide, but a personal guide as well. And it's a guide for the caregiver for their stress, and it's to help them. A lot of the books available for dementia caregivers are, this is how you help your loved one when they do this or when they won't do this. This is how you manage if they're wandering. This is how you manage them. I wanted to write a book about how do you cope and how do you care and survive this journey. And it's an unwanted journey. Nobody asks for this journey.
Absolutely. We're looking forward to seeing that book come out. Dr. Thorn, at Total Life, we aim to provide mental health services tailored to seniors. Many of those seniors, many of those listening today are dealing with chronic pain. For those that are listening that are thinking about therapy, can you share in your experience how therapy can help support and navigate an individual that is finding it difficult to manage their pain?
Some people are hesitant, especially if they have chronic pain. They're hesitant to go into psychological therapy because they think it's an admission that their pain is not real. They may have even been told by a physician that their pain is in their head, which, I just think that's so terrible when that happens to somebody. Their pain is real, and in a bizarre way, it is in their head because that's where the pain is processed. But it's not the implication that their pain is psychological. It's that either or thing again. It's organic or it's psychogenic. That's not true. We know that is not true anymore. And so if all you're doing is focusing on the physical, the organic, the medical, and you're not paying attention to that other huge part, the psychological, you're losing a good half of the benefit that you could be taking to help you manage a chronic illness.
And how does working with a therapist help navigate that chronic pain? Maybe from personal experience, you can talk about how you've helped people manage that pain.
So I think we all need coaches when we are when we're dealing with something that is really stressful in our lives. And therapists have been trained to hone in on the problem, not psychoanalyze anybody. That's not the aim of modern therapy. It's to help, first of all, somebody who's not intimately involved in your problem is listening to you. They're validating you. They are sort of restating what you say in a different way. And sometimes they're pointing out when you're engaging in, let's say, an unhealthy behavior. Wait a minute, 3 ice cream sodas in one day because you were stressed out? Let's talk about that. Let's talk about the long-term ramifications of that. I'm using a silly example, but you get what I mean. So a therapist is there to be objective but supportive. They're on team you, and they are focused in on you and listening very intently, and then feeding it back to you in a way that can help you move from point A to point B.
One of our missions at Total Life is to make therapy accessible and affordable. We make it accessible because It's available from the comfort and privacy of home. You can just dial in online, and it's affordable because we work with insurance payers to make it covered. So if folks are on original Medicare and a supplemental plan, often they pay nothing out of pocket. What advice do you have for seniors who are listening today, dealing with chronic pain, but are hesitant to try online therapy?
I was never a fan of online anything until COVID. And COVID, as terrible as it was in so many ways, it opened up the technology avenue for all of us to get more comfortable with online communication and online connection. And I will tell you, late into my husband's disease process and his dementia, and it was during COVID too, we had online medical appointments with the neurologist in Birmingham. We live in Tuscaloosa. That was a full hour away. And she said, can you imagine trying to get to Birmingham to get to treatment during this horrible process of disease that's going on? And I think it is so much more accessible. Online provides an accessibility that face to face just doesn't provide. When we were doing our rural outreach, we didn't have everybody come to the University of Alabama. We went to them because there was no way they could drive an hour and get to us. And that's what online therapy has really done for us. It's opened accessibility in a way that is remarkable, groundbreaking.
Absolutely. And if someone is in chronic pain, they might have mobility issues or, access issues. And this solves that for them. So, Dr. Thorn, what is the most important takeaway you hope our listeners remember from today's conversation?
I think the most important takeaway is you are not alone. You are not alone. There's a community out there that is dealing with similar things, but there's also help for you through behavioral health, through mental health, that you may not have ever taken advantage of. And now we have way more access to it.
Absolutely. I encourage everyone to check out Dr. Thorn's research and resources to implement these strategies. Her website is drbeverlythorn.com, and you can download her free patient-friendly workbooks. Join us next time for another insightful discussion on Mind My Age. Thank you, Dr. Thorn, for joining us today, and thank you to all of our listeners for tuning in. You can connect with Total Life at totallife.com and with me on social media. Don't forget to subscribe, rate, and review the podcast on your preferred platform. Stay mindful, stay healthy, and keep thriving. Until next time, this is Neelam Brar signing off.